I think understanding what we would deem to perhaps be a lower risk patient with ER-positive breast cancer is a very important issue for oncologists today. We know that the distribution of disease is important, so somebody with bone-alone metastases would be somebody that would be deemed a lower risk and might be somebody for whom an endocrine approach alone would be sufficient. I think one of the other key features is what we call the treatment-free interval. How long since their original diagnosis before they've developed metastases? We know if that time frame is relatively short, 1 or 2 years, then those patients might have a more aggressive phenotype, and often people have hitherto thought more along the lines of chemotherapy or now targeted combination treatment. Whereas a very long treatment-free interval of 5, 10, 15 years, and then relapse with just very small sites of bone disease in bone or soft tissue, those patients can have very endocrine responsive disease. And endocrine monotherapy could be a very good treatment option for many of these ladies.
Well, it's very interesting. It used to be that we would treat first-line ER-positive metastatic breast cancer that was indolent with a long natural history, minimal sites of disease. Those patients would just get endocrine therapy, and some would do well for many years. And patients with more sites of metastases, maybe some elevated liver function tests, symptoms from the metastatic disease, we would give them chemotherapy, oftentimes single agent reserving combination chemotherapy for those patients who really were in very substantial, life-threatening visceral crisis. Well, that paradigm has really changed dramatically in the last few years with the introduction of the CDK4/6 inhibitors. Now patients whose breast cancer really is ER-driven, most endocrine therapy sensitive disease with long natural history, ER-PR, strongly positive bone-only disease, lung disease tends to be ER-driven, those patients benefit greatly from the addition of a CDK4/6 inhibitor. So it's no longer endocrine therapy by itself, it's the combination therapy. And conversely, patients with a fair amount of metastatic disease, multiple sites involved, liver function abnormalities, symptoms from their disease, short natural history, fast development of metastatic disease, we're treating those patients as well with CDK4/6 inhibitors, with endocrine therapy, and not going to chemotherapy, because the benefits from the CDK4/6 inhibitors, they work just as quickly, it appears, as chemotherapy. We don't have randomized comparative data yet, but just looking at how quickly patients benefit, the response rates are at least as good, if not better, than even combination chemotherapy. But most importantly, the duration of benefit, the median progression-free survival, is all around 2 years in all the studies, which is much longer than we would get from chemotherapy. So we're really reserving the chemotherapy for those with the most immediately life-threatening disease, but even that may change over time. The CDK4/6 inhibitors may end up being superior even to combination chemotherapy.
We think of primary endocrine resistance as being mainly clinically, it's a clinical diagnosis. In the past, we've said if patients were receiving an adjuvant endocrine therapy and they progressed within the first 2 years of that adjuvant endocrine therapy, that would be associated with endocrine resistance. Similarly, in the metastatic setting, if a woman presented and was treated with endocrine monotherapy, such as letrozole for a postmenopausal woman, and she progressed within 6 months, that this would be considered primary endocrine resistance. What are those factors that are associated with endocrine resistance? Well, we know things such as low levels of ER. Clearly, we know that in the past it was overexpression of HER2. There are data with regard to EGFR. We know that there are other factors, however, patients that have cyclin D1 amplification, patients with other growth factor receptors activated, such as FGFR. So there's a number of these factors. Didn't mention P53 mutations, which generally are associated with a worse prognosis. But these are factors we're identifying right now as those that, if we knew about them up front, and in combination with those clinical factors, might suggest that that patient is at higher risk for primary endocrine resistance. Now, in the setting of CDK4/6 inhibitors, we haven't defined as of yet what primary and secondary resistance is to CDK4/6 inhibitor combinations. But I suspect, at least in the metastatic setting, we're talking about perhaps progression in less than a year. and that would be about half the, if you will, if the median progression-free survival is 24 months, if someone progressed within 12 months, that might suggest, if you will, a primary resistance to CDK4/6 inhibitors. And we're increasingly understanding some of those factors that are associated with resistance to CDK4/6 inhibitors, but we still have quite a bit to learn.